This is Chapter 12, Caring for the Woman Experiencing Complications During the Postpartum Period. So we're going to talk about several different things that can occur during the postpartum period. First, we're going to talk about postpartum hemorrhage, and this is probably one of the most important things that we watch out for, and I know I've talked about this a lot, but it is very important that we are monitoring and assessing for postpartum hemorrhage. Because this is the leading cause of maternal morbidity and mortality in the United States. So you can see why it's such a huge deal to be able to assess and identify this. So when we talk about postpartum hemorrhage, it's a blood loss greater than 500 milliliters after a vaginal birth or greater than 1,000 milliliters after a cesarean birth. So 500 after a vaginal, 1,000 after cesarean, okay? And when you see EBL in the patient's chart or in your paperwork, that stands for estimated blood loss. So you should be able to find that in the chart as far as clinical is concerned, and that's what they're looking at. What is the estimated blood loss during the delivery, and how is the patient's bleeding since the delivery? Okay, so EBL stands for estimated blood loss. So just remember 500 vaginal, 1,000 cesarean. And if you look at page 407 in your book, table 12-1 shows PPH terminology. So you see readiness, recognition, response, reporting. Just know what those terms mean when we talk about postpartum hemorrhage. Because early recognition is key. So that's part of what that is as far as recognizing that. We want to assess and monitor for blood loss and perform that fundal assessment after delivery. Pads may be weighed for accuracy depending on how the bleeding is and how it's estimated. Remember that the blood pressure is the late indicator. We talked about this in the last chapter. We talked about the assessment of the mother. So remember that blood pressure is a late indicator. So we're going to watch for that heart rate greater than 110. We're watching for that tachycardia. And we're watching for an O2 sat less than 95%. So once that blood pressure starts decreasing, that's going to be a late sign. Hopefully we've caught it before then. So watch for the heart rate greater than 110, O2 sat less than 95%. Okay? Now let me explain what early and late PPH means. So early is considered primary. It's also called primary postpartum hemorrhage. This occurs within the first 24 hours after delivery, with the highest incidence being within those first 4 hours. Okay, so it can occur anytime within the first 24 hours, but the highest incidence is within those first 4 hours. The early PPH is usually caused by subinvolution. Remember what I said that was. Subinvolution was when the uterus does not contract back down to its normal size. Okay, so early is also called primary within the first 24 hours, the highest incidence within the first 4 hours. Late is also called secondary. It occurs from the first 24 hours, that 24-hour mark, up to 12 weeks after delivery. Okay, so late is from 24 hours after delivery up to 12 weeks. That's a long time, right? That they need to be watching this. And that is usually caused by retained placental fragments. Okay, so early, usually because of subinvolution. Late, usually because of retained placental fragments. Now, the 4 T's of postpartum hemorrhage. When we're assessing for postpartum hemorrhage, let's remember the 4 T's, okay? Tone, trauma, tissue, and thrombin. So that's what we're looking at when we're talking about the 4 T's. Tone, trauma, tissue, thrombin. Now, the tone is the uterine atony. That means it's the failure of the uterus to contract following delivery. This is the most common cause. So the tone or uterine atony is the most common cause of postpartum hemorrhage. So if you look on page 407 at the bottom, box 12-1 show you risk factors for uterine atony. A lot of times it's when the uterus has been overdistended. Maybe there was a prolonged or dysfunctional labor. There's a previous history, and you can read the rest of them. But uterine atony is the most common cause. Remember that. Uterine atony, most common cause. Assessment of this would reveal dark red bleeding with a lot of clots and a boggy fundus. Okay? Dark red bleeding, clots, a boggy fundus. Now, trauma. This means soft tissue trauma from lacerations, episiotomies, and if you flip over to page 408, you're going to see box 12.2 at the top, which should be risk factors for tissue trauma. So box 12.2 on page 408. So assessment of this would reveal bright red bleeding without clots and a firm midline fundus. So we're not looking at we are looking at the fundus, but that's not the cause because it's firm and it's midline. That's how we want it, right? So we're going to see bright red bleeding, no clots. That's going to give us an indication that it may be related to some trauma. Then the tissue. Tissue would be retained placental tissue. Okay, remember I usually said that's the cause of late PPH. The placenta should be examined thoroughly after delivery to make sure that it's all intact. It's always assessed, it's always looked at after delivery to make sure it looks like it's all together. Okay, so assessment of this, if there's an issue with tissue, would reveal dark red bleeding with clots and a boggy fundus, once again, just like the tone. Okay. Thrombin means there's maternal coagulation issues, and we've talked about DIC before, but it's maternal coagulation issues. Now, there's a disease called von Willebrand disease. It's a common hereditary bleeding disorder, and it places patients obviously at increased risk for PPH. It's called von Willebrand disease, very common hereditary disorder. So management, what do we do? I wanted to be, you can see the treatment for the different ones on the slide here, but I wanted to be specific about TIF Regional. They do perform PPH assessments on admission of every patient, right before delivery of every patient, and right after delivery of every patient. And obviously they're checking the fundus and all that, every assessment that they do that the nurse does following that. But a specific PPH assessment is done on admission, right after delivery, right before delivery, and right after delivery. And that's their protocol to do that, okay? So the fundal assessment obviously is critical when we do the assessment for that. Remember, we're not going to rely on vital signs as the only indicator because there can be a large loss of blood volume before changes start to occur in the vitals. So we're going to be doing the other assessments, looking at the lacerations, feeling for the fundus. Remember that video on the fundal massage. So if you didn't watch it with the last chapter, watch it with this chapter, okay? And if you look over to page 410 and 411, this shows you how to do a fundal massage. So this procedure box in your book on page 410 and 411 shows you how to do that step by step. And if you did not watch the video before with chapter 11, please watch it with this one because it's really good to help you understand how to actually do that fundal massage when the uterus is boggy, okay? So it's very important to give you that visualization to help you understand that. Also, we're going to watch another video in class together. It's a simulation drill of a group of people actually running through a PPH simulation and what happens, what they do, how they all come in and how they help. But you can also look on page 409, if you'll flip back one page to 409, and you'll see the medication box there for Methergin. You're always going to assess the blood pressure for hypertension before administering Methergin. Please remember that. Always assess the blood pressure for hypertension before administering Methergin when that is given, okay? Because that's one of the medications that's very commonly given when a woman has postpartum hemorrhage due to uterine atony, okay? So that's one of the treatments there for that. And you can see some other meds. If you'll flip back to page 411, you'll see table 12-2 for some other meds there that are given, but that one specifically gave you some more information as far as that. But remember checking that blood pressure before Methergin is given, okay? We're going to watch a video in class about the simulation drill. Now, another thing that can happen is hematomas. Hematoma develops when there is localized bleeding outside of the blood vessel. That bleeding goes into the connective or soft tissue. Usually this happens following an injury. So during labor, these occur most often on the vulva. They can occur in the vagina and the retroperitoneal area, depending on what happens, okay? So look at page 413. If you flip over there, figure 12-2 and 12-3 show you these hematomas, okay? So risk factors, You can see these listed here on the slide. Genital tract lacerations, if there's an episiotomy, operative vaginal deliveries. Remember, operative vaginal deliveries means using the forceps or having to use the vacuum assist. Difficult or prolonged second stage of labor, and nulliparity, that means the first pregnancy. And because remember, usually first pregnancies have prolonged labors. Okay, so you can see those pictures there on page 413. Signs and symptoms. The most common sign and symptom that you're going to see is unremitting pain and pressure at the site. They may complain of vaginal or rectal pressure, and the fundus remains firm because you're still checking the fundus. The fundus is firm. So when you look, there's an assessment when you're looking at that, remember the perineal assessment that we do. It's part of that bubble he, okay? We're doing that perineal assessment. You're going to see a bluish discoloration, bulging tissue at the site, and it's very, very tender if you touch that area. They may have absent lochia. This is important. They may have absent lochia because maybe it's swollen so much that it's not able to get out. They may have the inability to void because of the swelling, okay? And you're going to monitor for signs of shock. So what do we do about this? The collaborative management, what do we do? So you're going to notify the physician. If the hematoma is less than 3 to 5 centimeters in diameter, you're going to administer ice packs and pain medication for relief, and you're going to monitor closely for those first 12 hours. After those first 12 hours, if it still remains small, 3 to 5 centimeters, okay, then sitz baths would replace the ice packs. So you're going to give the ice packs for 12 hours, okay? Pain relief, watching, then do sitz baths after the 12 hours to replace the ice. If the hematoma is greater than 5 centimeters in diameter, an incision and drainage may be necessary. So that's why it's important to monitor that, especially if she's complaining of pain and pressure at the site. Thrombophlebitis and thrombosis. Now, both thrombophlebitis and thrombosis describe inflammation that occurs due to blood clot formation within a vessel. Usually, this occurs in the lower extremities. So most concerning during pregnancy are these three right here we're going to talk about. So superficial venous thrombosis involves the superficial saphenous venous system. Deep venous thrombosis, this is where we get DVT from. This may extend from the foot to the iliofemoral region up to the groin area. A pulmonary embolism is actually a complication of a DVT, and this occurs when part of the blood clot dislodges and it actually travels to the pulmonary artery. So you can see why these three would be concerning, obviously, and these three are usually the conditions that you're going to see in pregnancy. So thrombophlebitis and DVT are a leading cause of maternal mortality. So it's very important that we're assessing that as well. There's an increased risk during postpartum because of venous stasis. And remember we talked about earlier, don't want to get too far ahead because I'm going to talk about it on the next slide, but we're going to talk about what to do. And I mentioned it a little bit in the last chapter. We're going to go into a little bit more detail about what to do. So let's talk specifically about deep venous thrombosis or DVT. Signs and symptoms, and you can look here on the picture I put here, kind of show you a little bit of information. You'll see the pregnancy risk there and what we're going to do, treatment, risk factors, okay? But let's look at the signs and symptoms. Up to 50% of patients are asymptomatic, okay? But you can experience unilateral leg pain, but up to 50% are asymptomatic. Sometimes they'll have unilateral leg pain. They may have calf tenderness, edema, redness, localized warmth, but 50% may be asymptomatic. Remember last chapter I mentioned about the Homan sign, a positive Homan sign, okay? Remember that's presence of pain in the calf when the foot is dorsiflexed, okay? So that is part of one of the signs and symptoms that can occur as well. But remember, that's not a definitive thing because sometimes they may not have a positive Homan sign and they may have a DVT, okay? But a positive Homan sign means that they do have one. We can draw labs. We can do a D-dimer, a basic chemistry test. We can do a PT and a PTT. Those can be done as well to determine what's going on with the patient. Collaborative management. We're going to identify the patients at high risk, and you see the baseline risk here, okay? Prior issues with clotting, maybe a prior DVT, a known thrombophilia, if they're obese, if they have immobility, and look at the pregnancy risks here on top of your baseline risk. Their gestational age, multiple gestation, did they have artificial reproductive technology, meaning any kind of assisted reproduction, preeclampsia, postpartum infection. Those are the risk factors we're looking for to identify the women that would be most at risk. We want to prevent this, if we can prevent this. Remember when I talked about the compression stockings and then those automatic compression devices that are placed on the legs? We want them up and walking as soon as possible, because the longer they lay in the bed, the more risk they have. So we want them up and walking as soon as possible, walking around the room, getting up, going to the bathroom, things like that. I put this in red on the slide. Do not massage the extremity, okay? We don't want it to break off, so do not massage the extremity. That's very, very important, because it may, when you have a cramp in your leg like a Charlie horse in your calf, that's the first thing you want to do is rub it, right? It makes it feel better when you rub it. Do not massage the extremity and tell the patient not to do that as well. So treatment for this, heparin is used to treat a DVT while they're hospitalized. So they're going to be given heparin to kind of dissolve this clot when they're in the hospital. When they're discharged, they're usually going to be given warfarin, so they can take warfarin at home, okay? The heparin in the hospital, warfarin when they're discharged. Patient education. Now, this is important for them, especially following discharge. So they should avoid medications that contain aspirin, NSAIDs, while they're on this anticoagulant therapy. So they want to avoid aspirin products. Follow-up lab testing is important, so they're going to have to come back in to have that follow-up lab testing in case their medication has to be adjusted. So we want to make sure that we explain why it's so important for them to come back for those follow-up lab visits, okay? So that can be monitored where they are, okay? Now this is puerperal infections, which basically means postpartum infections, okay? So this is a bacterial infection that occurs within 28 hours after a miscarriage, an induced abortion, or childbirth. So this is some type of bacterial infection that occurs, and we're going to talk about specific ones. But this is within 28 hours after some type of birth, whether it's miscarriage, abortion, or childbirth. So these most commonly involve the endometrium, an operative wound, the urinary tract, breast. I'm going to talk about the specific ones. So for the endometrium, this is the most common infection during the postpartum period. This is inflammation of the uterine lining, and it usually presents with a temperature of 101 or higher. Usually they're going to have tachycardia, uterine tenderness, suprapubic pain, and subinvolution would be a late sign, and foul-smelling lochia would be a late sign. So the endometrium is the most common, and you heard the signs, but subinvolution and a late sign would be that foul-smelling lochia as well. So hopefully we've caught it before then, because we're monitoring those vital signs and how she's feeling. Wound infections, so this obviously would be a C-section patient, okay? It can also occur from an episiotomy. Usually it's going to be your 3rd or 4th degree episiotomies that you're going to have more risk for infection. Mastitis is the breast infection. So this is an inflammation of the mammary glands. I talked about this a little bit the other day. Usually you're going to see unilateral pain, and it can cause milk obstruction, and it leads to engorgement, okay? So if you look on page 417, we're going to flip over a few pages here to 417, and you can see mastitis on the right-hand column. Those bullet points is going to show you the signs and symptoms for mastitis specifically, okay? You're going to have pain in the affected breast, fever, chills, tenderness, warmth, nipples may be cracking, and you're going to treat this. Oh, you can look over on one other page. Sorry, page 418, figure 12-6 shows you kind of what happens, how mastitis can occur. So you're going to treat them with antibiotics, can maintain that breastfeeding, okay, because we don't want the milk to dry up, so you're going to maintain the breastfeeding. A lot of times they're going to give an antibiotic that's safe for the mom that's breastfeeding, okay. And then if you look on page 419, Table 12-3 goes into a little bit more detail with specific ones, but basically what I said, but gives a little bit more detail as far as risk factors for the specific ones. If you look back to page 417, you will actually see the risk factors in the left-hand column. Poor hygiene, low socioeconomic status, smoking, malnutrition, obesity, comorbidities such as diabetes or hypertension, and then infections during pregnancy. So any STIs, if they had a UTI during pregnancy, anything like that can be an increased risk factor for them. Prevention is a lot of education for the patient. So hand washing, proper hand washing, using that little peri bottle to clean the perineum, especially if they have episiotomies. We want to make sure that they're using that little peri bottle to clean the perineum after each restroom visit. Change their peri pad at least every 3 to 4 hours, if not more, depending on the bleeding. Drink extra fluids to help increase their urine production. Washing their incisions with soap and water when they are able to do that. Okay, at first, obviously, they won't be able to get it wet, but washing their incisions with soap and water. Maintain glycemic control if they're diabetic. And then lifestyle changes such as smoking cessation as well, since that's a risk factor. So signs and symptoms to report: pain, redness, or swelling at the incision site. Obviously, they need to report that. If they have a temperature of 100.4 or higher. And then it's important to provide patient education to encourage them to follow up with their appointments, especially those that first 6-week appointment, and then the following ones after that. They need to make sure they're following up with their doctor. Postpartum psychosocial complications. So emotional, spiritual, relational, and socioeconomic concerns, all of that plays into their psychosocial complications. They may not recognize the need for help. Remember, we talked about earlier how, sometimes moms just think this is how it's supposed to be. This is how I'm supposed to feel. I'm supposed to do all of this. And they may be reluctant to ask for help because they just think that's the expectation. That's just what they're supposed to do. And the nurse can be a lifeline for the woman experiencing any type of psychosocial complication. And I know we went into a detail last chapter, in chapter 11 about this, but I'm going to go into a little bit more and give a little bit more information so you can kind of add to what I said in chapter 11, because we're going to talk about the postpartum blues, postpartum depression, and postpartum psychosis. And like I said, this information will just be added to what I already said in chapter 11. And remember, I said it's important to know the difference, and I said this for the last chapter as well. It's important to know the difference between the postpartum blues, postpartum depression, and postpartum psychosis. So postpartum blues is very common. Remember, I said that before. It's periods of tearfulness, mood swings, shifting emotions, and all that. It is self-limiting. Okay, it's self-limiting and usually resolves by about 10 days postpartum. And it is very common because 50 to 80% of women experience postpartum blues. We've just been through all this, our body physically has been through all of this stuff, and it could be hours and hours of labor that our body has physically been through, and then there's a sharp decline of hormones where our body has had these throughout the pregnancy. So then there's this significant sharp decline of our hormones. So you can see how, within those first 10 days, our body's trying to readjust, okay? 50 to 80% of women, but this is self-limiting and usually resolves by about 10 days of postpartum. Signs and symptoms: tearfulness, mood swings, anxiety, fatigue, sadness, insomnia, forgetfulness, and confusion. Alleviating factors: resting, reassuring this mom and encouraging her, and providing support. And it's important that she has that support, whoever it is it's from, whether it's the dad or a friend or relatives or whoever. She needs some support, and the nurse can provide that as well within the hospital setting, depending on how long she's there. Postpartum depression. Now, this usually occurs within 6 months postpartum. So anytime after that 10-day period, postpartum depression can actually occur. So 10 to 20% of women progress from the blues to the depression. So 10 to 20%, they start having the postpartum blues and then it progresses into postpartum depression. Postpartum depression can significantly impact the mother, the infant, and other family members because the woman is more likely to develop a mental health disorder as well. So you can see how this is going to impact the mom, the baby, other family members in the home, and then it may have long lasting effects because she is more likely to develop a mental health disorder. Signs and symptoms. Look at page 421. You can see box 12-3 shows you the signs and symptoms. So anorexia, weight loss, insomnia, and some of that is like, okay, is this related to my lack of sleep because of the baby, or is this related to postpartum depression? But we talked about this earlier. Withdrawing, decreased self-esteem. This is what goes along with those other symptoms that is a very strong indicator that it's postpartum depression. So withdrawal, decreased self-esteem, feelings of worthless or hopeless, suicidal thoughts, okay? So a depressed mood almost every day for at least 2 weeks, recurrent thoughts of death. They can even have thoughts of harming their baby. So it's very, very important that we are monitoring for this in that postpartum period. And then when they go for those follow-up visits, that's why it's critical for them to go for those follow-up visits, so that they can be a continued assessment of their psychosocial status. Now, assessment. Do not wait to assess until after the baby's born. Okay, this is important. We're not going to wait to assess because it's called postpartum depression. We still don't want to wait until after the baby's born. This should start at the first prenatal visit because we're trying to identify risk factors. Is this mom more likely to have postpartum depression? We're looking for risk factors. We're looking for psychosocial adjustments of the mom. That's in the prenatal period, during those prenatal visits. Now in postpartum, we're watching for bonding issues. We're watching has the mom given the baby a name? Does she seem interested in taking care of the baby, holding the baby, feeding the baby, changing the baby? Or is she completely uninterested and leaves the baby in the bassinet over on the other side of the room? Okay, we're watching for bonding. We're watching for feelings of failure, whether it was the birth process. Did she want to have a vaginal delivery and ended up having to have a C-section? Did she want to do a natural vaginal delivery and ended up getting an epidural? So did she feel like a failure during the birth process? How is she in succeeding at breastfeeding? Or does she feel like a failure because she's having trouble breastfeeding? Lack of sleep obviously is a big one. No support is a big one. So we're looking for those things in the postpartum period as well. Now there's an assessment tool called the Edinburgh Postnatal Depression Scale. There is a link in the Lesson 3 folder or Module 3 folder where you can look at this to see how it's scored, questions that are asked, and what you're looking at and assessing. It's called the Edinburgh Postnatal Depression Scale. Very common tool that's used pretty much universally for this postpartum depression. So make sure you look at that in the Module 3 folder. I'm going to explain what the scores mean. So it gives the woman a score from 0 up to 30. So a score of 13 or higher is an indicator of the woman having increased risk for developing depression. So 0 to 30 with 13 and up being an indicator of increased risk for depression. Collaborative management, cognitive behavioral therapy, interpersonal psychotherapy, both of those things have been very successful. If she has moderate to severe symptoms, meaning she's having thoughts of harming herself or harming her baby, those are moderate to severe symptoms. She may be given an SSRI or an SNRI. Those may be prescribed for her. And if you look over on page 422, table 12-4 shows you some common medications that can be used to treat postpartum depression. Like I said, most commonly it's going to be your SSRIs or your SNRIs. And those, you can look over to the far side. If she's breastfeeding, you can see that there may be some effects to the baby But once again, you have to think, do the benefits of taking this medication outweigh the risks? Okay, so some of these do have risks to the baby, but you have to think, do the benefits outweigh the risk? So medications are prescribed for moderate to severe symptoms. And I put this on here for you to go back and be able to see what the difference is. It's a side-by-side comparison. I like to look at these so that it helps me, in my mind, keep them straight. A side-by-side comparison. So baby blues on the left, postpartum depression on the right, and it really shows you the difference in the two. Okay? So just make sure you go back and look at this slide. Now, postpartum psychosis I talked about earlier. Remember, it's a rare condition, but it is an emergency if it does happen, okay? Because it affects not only the mother, but it affects the entire family. So those with pre-existing psychosis, especially if they already have bipolar disorder, they are more susceptible. So if they have a diagnosis of bipolar disorder already, they are more susceptible to developing postpartum psychosis, and the healthcare providers taking care of this one would be watching for that. To distinguish psychosis from postpartum blues or postpartum depression, we're going to look at the symptoms. So hallucinations, delusions, they become agitated, they have confusion, they become disoriented, they have sleep disturbances, they have suicidal thoughts, homicidal thoughts, a loss of touch with reality. And you can look on page 423 in that little box there on the left-hand side that shows you behavioral cues that would signal the patient is moving into postpartum psychosis. So what do we do for these women if we see that they're developing the psychosis? So these women have a very high danger of killing their infant because of these hallucinations and delusions. They don't know, they're out of touch with reality. So there's a very high danger of them killing their infant. So prompt treatment is necessary. That's why we're identifying risk factors ahead of time. They're going to be hospitalized. They're going to be placed on antidepressants, mood stabilizers, antipsychotics. They will probably be in long-term cognitive behavioral therapy as well. So when I say this is an emergency, it is. Okay, so we really have to pay close attention to that. Childbirth-induced post-traumatic stress disorder. So this is a reaction occurring after experiencing a very highly stressful event. So in this situation, it would be something very highly stressful that occurred during the delivery. It's characterized by depression, anxiety, flashbacks, recurrent nightmares, avoidance of reminders of the event. And the women at risk most of the time are going to be your nulliparous women, the women that had prolonged labor for whatever reason. Maybe there were shoulder dystocia, a breech delivery, anything like that that's out of the norm can cause a childbirth-induced post-traumatic stress disorder. So that should not say routing screening, that should say routine screening. So we're going to routinely screen these women, especially in that postpartum period before they're discharged, to make sure they're not having any post-traumatic stress symptoms, okay, especially if they've had that traumatic birthing experience. And again, that should say routine, not routing, okay? All right, so this was a little bit shorter chapter just because we had talked about some of these things earlier, but we are going to do some activities in class as well.